The American Brain Tumor Association is pleased to welcome you back to our webinar series. Our webinar topic today is Latest and Greatest in Brain Tumor Research. My name is Umbreen Maan, Program Manager here at the ABTA, and I'm delighted to introduce our speaker. Dr. Aaron Mammoser is a neuro-oncologist at the Piedmont Brain Tumor Center. He treats tumors of the brain and spine, CNS lymphoma, brain and spine metastases, and neurologic complications of cancer. He has a special interest in clinical trials for treatment of primary and metastatic brain and spine tumors. Dr. Mammoser prides himself on helping people maintain their quality of life and mitigate short and long-term effects of diagnosis and treatment of brain and spine tumors. Thank you so much for joining us, Dr. Mammoser. You may now begin your presentation.
Thank you for that introduction. As Umbreen said, my name is Aaron Mammoser. I'm a neuro-oncologist at Piedmont Brain Tumor Center. Thanks for attending my talk today, Latest and Greatest in Brain Tumor Research. This is meant to be a practical discussion for patients and families. So as an overview, we'll touch on what is research. We'll take a look back at glioblastoma treatment throughout the years. We'll talk about reasons to participate in clinical research. Talk about how to get involved in clinical research, talk about some of the active areas of research in brain tumors, look at some of our recent successes, and talk about what the future may hold. So what is research? The Oxford Dictionary defines it as systematic investigation into and study of materials and sources in order to establish facts and reach new conclusions. This is a fairly pragmatic description of research that doesn't necessarily take into account a lot of the day-to-day aspects of it. Research is, I kind of think of it more as a balancing act. When somebody has an idea and is looking to move forward with a research project, they look at it in ideal terms. If they had unlimited resources and they have a question, say, I have a drug, how do I determine whether or not this drug treats a condition better than the current regimen? They put together an ideal situation, often looking at different exploratory aspects that they would like, data that they would like to collect. The flip side of that, the balancing act, is dealing with it in a more real-time or more dealing with the logistics. We often have limited resources. We often, in terms of a clinical trial, are asking subjects, patients to bear a certain amount of burden to enroll in these trials. And so what we end up doing is kind of a compromise between what we would idealistically like to do and what we're able to do in a way that still answers the question and hopefully provides an answer. Given my background as a neuro-oncologist, most of the time when I think of research, I think of it in a bit of a narrow lens. Think of it in terms of clinical trials, taking an investigation, taking a drug or other modality and seeing if it treats tumors or people with tumors better. Most of the time when patients are asking me about research, this is the question that they're asking. If we look at the sessions from the 2023 Society for Neuro-Oncology meeting in Vancouver, what we see are that are clinical trial specific are a number of sessions that occur over the course of a 3-day meeting. Most of these sessions have about 11 or 12 presentations as part of them. Many of them are clinical trial specific. Some of them are talking about some recent advances or educational topics and including means of working research into them. So you can see that clinical research covers a significant portion of these meetings. In reality, though, there's a lot more that goes into research. As you can see, there's the basic laboratory or the preclinical aspect of research. These are the folks who are toiling at the bench to come up with all of the information on tumor cells or metabolic pathways or other pathways that we ultimately are looking to target with these in a clinical trial. The clinical aspect of it, in addition to the clinical trial itself, there are also observational studies. Many times we're looking at patients with a certain diagnosis and looking to see how they behave in real time, making observations and putting together information that drives the questions that ultimately lead to clinical trials. There's also the epidemiological aspect of things, looking at gathering data on people who are affected by these conditions and determining how best to put together studies. These are also studies that look at things like quality of life and other aspects of clinical trials and treatments. One of the things that's not well represented in this slide is the translational aspect of it. These are researchers that have a foot in both the basic science aspect and the clinical trial aspect. When you hear of people taking an idea from bench to bedside, these are often translational researchers that are at the heart of driving clinical trials forward. As I was saying, brain tumor research is so much more than just the therapeutic clinical trials. Going back to that SNO meeting in 2023, there were numerous basic science sessions, a full 6 different sessions looking at recent research, basic science research or preclinical research. This is often where we learn the most about tumor microenvironment and immune regulation that drives many of the current treatment modalities. There are numerous imaging sessions. As technology advances, as artificial intelligence and other applications are moving forward, how do researchers take that technology and use it for imaging to be able to come up with better diagnostic imaging, come up with imaging that's helpful in determining prognosis, as well as certain advanced imaging techniques that give us more information into tumor composition, as well as into basic everyday neurologic functioning. Neurosurgery sessions where researchers are taking newer strategies and looking at older approaches to surgery, thinking about things like supramaximal resection, where if a tumor is in a location that you can do an extensive surgery, how does that impact a patient? How does that impact their outcome? We'll talk a little bit more about focused ultrasound later in the talk. Radiation sciences, that's a lot of physics and stuff, so I'm going to leave that one alone. Pathology. So over the last 15 or 20 years, this is probably the area that there's been the most progress in our research in brain tumors. When we look back to 2021, the WHO classification system was revised to take into consideration some of the molecular pathology that we've come to understand better over the last 10 years. Other things that pathologists are looking at are treatment response biomarkers. So, currently our best means of assessing treatment response is through imaging or possibly invasive techniques such as surgery or biopsy. Whereas as our techniques become more advanced, we may be able to do this with things like liquid biopsy, looking at circulating tumor DNA. This is something that's being done in other systemic cancers, but because of the blood-brain barrier has been more of a challenge to use in brain tumors. Neurosciences, so there's been an explosion of information over the last 5 or so years looking at how normal neurologic function and neurologic processes impact tumor development and tumor progression. As we were talking a minute ago, most of this was directed at primary brain tumors. There's also a ton of research going on in CNS metastases. There are always statistic sessions on statistics, looking at better ways of designing trials for more efficient looking at more efficient trial design to come up with answers quicker. Topics like survivorship or adolescent, young adult issues have become more commonplace over the last several years as we recognize that adolescents and young adults bear different burdens of treatment and outcomes than some of our older patient population. Health disparities, so looking at ways of making sure that people from all different walks of life have access to all different types of brain tumor treatment. Outcomes research, so looking at quality of life impact of many of our studies, many of our treatment approaches has become commonplace in clinical trials over the years to make sure that not only are we coming up with more effective means of treatment, but that the impact on people's lives is minimized. Pediatrics is also covered widely at the SNO meetings, although they have their own offshoot meetings as well, recognizing that the biology and the issues facing pediatric patients are often very different. RANO stands for the Response Assessment in Neuro-Oncology. As our treatment approaches have progressed over the years, things like anti-angiogenic medications, so medications that limit blood vessel formation, or immunotherapies, or other approaches, radiation, for example, as these treatments impact the way our MRIs look, we have to have a better way of determining what we're looking at. Is it an effect of the treatment, or is it progression of a tumor? And so the Response Assessment in Neuro-Oncology Working Group has been looking at means of coming up with better response assessment over the years. With all that being said, the focus of our talk will be on clinical trials in neuro-oncology. Giving a little bit of background on clinical trials, some of the things that you can see are pilot studies. These are often small early phase feasibility trials, not necessarily phase one where you're looking at drug toxicity or dosing, but looking at things that may already be approved for other indications, and it's a small trial to increase the likelihood of success if the trial was to go forward in a randomized controlled trial. Phase one trials, these are often early phase trials. There's often decades of development that go into drugs, including preclinical studies and animal models and things of that nature. By the time these drugs get to phase one, when they get to phase one, these studies are often looking at dose finding to determine what dose of a drug to use in subsequent trials, as well as safety. Traditionally, outcomes such as survival or progression-free survival were not often looked at. However, as we advance in trial design, often these things are tracked potentially to roll into an ensuing phase two trial. So phase two trials, these are generally a little bit larger, enrolling anywhere between 25 and 100 patients. They can be single-arm trial or randomized. They're looking for the first signs of effectiveness, as well as continuing to look at toxicity. Looking for signs to take a drug forward into a larger phase three trial. Phase three trials, these are also known as registration trials. When you think of a clinical trial, these are usually of drugs or treatment approaches that have undergone extensive testing and have had favorable toxicity profile, as well as signs of effectiveness along the way. If these trials are positive, often they will go, or the drug being studied will often go on to FDA approval. These are generally randomized studies. I kind of touched on phase 1-2 trials a little bit earlier. So these are a mechanism by which a phase 1 trial, assuming that the toxicity is favorable, the subjects who were treated at that eventual phase 2 dose are also rolled into a phase 2 trial to take more advantage of accumulated data. Phase 2-3 trials, these are becoming more commonplace. As a phase 2 trial is enrolling, looking for evidence of effectiveness, often there are benchmarks set for the trial. So as it's being evaluated, as it's being run, if it meets certain metrics, it can be rolled into a larger phase 3 trial. Reasons for doing these combined trials are the machinery put together to run a trial it's more efficient to be able to roll one trial into another than to go through the process of trying to acquire funding and set up the trial once the phase 2 has continued enrollment. We'll touch on some of these more unique trial designs, such as phase 0 trials, a little bit later in the talk, as well as window of opportunity trials. Phase 0 trials are intended to speed up and streamline the drug approval process. In these patients or in these subjects, usually what you're looking at is somebody who we know is going to undergo surgery, but it's not an urgent situation. They have some time. They don't need to undergo surgery immediately. Often, holding off for a week or so is not considered to be detrimental to their outcome. In these situations, a drug that's being studied is often administered at subtherapeutic doses prior to the surgery. It could be days prior, it could be hours prior. At the time of surgery, tissue is obtained and then evaluated to look for things such as drug penetrance, the concentration of drug that gets into the tumor, and early evidence that the drug is working as predicted. Window of opportunity trials are similar to phase 0 studies. In these trials, you can, in one version of these trials, patients who are demonstrating benefit or demonstrating optimal dosing and evidence that the drug is working as predicted may go on to a therapeutic dose of the drug. Other evaluations that are done in window of opportunity trials, often tumor tissue is looked at to see what pathways are activated, or other exploratory studies are performed to see the outcome or the impact of drug administration. So moving forward, I'd like to take a look back at glioblastoma treatment throughout the years. So here's a timeline going from 1970 to present day. Back in the late 70s, early 80s, evidence demonstrated that steroids were found to improve neurologic function, decrease edema, and decrease permeability of the blood-brain barrier. When you think of 1980, that's not too long ago, a little over 45 years ago, or a little under 45 years ago. This is around the time CT use, MRI use was becoming mainstream, and we were obtaining more evidence on how to treat brain tumors. Prior to that, there was a lack of precision. In the early 90s, there was a meta-analysis done of 6 studies that were done across a 15-year timeline that demonstrated survival benefit in people who underwent radiation after surgery for a brain tumor. Over the course of the 2000s, studies were demonstrated definitively that there was a benefit of resection in patients with glioblastoma. So prior to 2000, there was a lot of debate about whether or not doing a more extensive surgery to remove tumor was helpful. As surgical techniques evolved and as our understanding evolved, we realized that even removing as much as 78% of a tumor was likely to have a beneficial effect on their long-term prognosis. Over that time frame in 2005, our current standard of care was established. The STOOP trial, establishing radiation with concomitant temozolomide as the standard of care for people with newly diagnosed glioblastoma. In 2014, the Tumor Treating Fields, or the Optune study, developed or demonstrated additional survival benefit. You can see that over that 54-year period of time, there were limited positive studies in that in patients with glioblastoma. So why should I participate in clinical research? For the most common types of primary brain tumors, diffuse gliomas, regardless of grade, consisting of astrocytomas and oligodendrogliomas, there's currently no cure. So, one of the things that's commonly, joked about is the fact that, our treatments are great if you're a mouse, but they don't seem to work as well once we get out of the preclinical setting. So looking at the NCCN guidelines, so these are guidelines that the National Comprehensive Cancer Network puts together for all different tumor types, not just CNS tumors, but breast, lung, etc. The first recommendation is always consider a clinical trial. So this is the pathway for newly diagnosed patients. This is the pathway for recurrent patients with malignant glioma. And so as we're thinking about, why participate in a clinical trial, I want to make sure that people understand what clinical trials are not. So these are not a guarantee of treatment with an investigational agent. So, for randomized studies, as you participate in a study or as you enroll in a study, there's a chance that you will be put on a standard of care arm. There are not placebo-only arms in cancer treatment, but you may be on an arm that is just the current standard of care. These are not a guarantee that you'll be put on a treatment, even if you're on the investigational arm, that'll work better than standard of care. There's a lot of evidence that goes into these studies, and we believe that they should be effective, but that's not always the case. The other thing that I'd like to say is that the outcome of these studies is not something that can generally be predicted prior to the study data being analyzed. I often get asked, what's a good study for me to participate in? I can say that over the course of my career, there have been many studies that, as they're enrolling and as we are learning more about the approach, we feel that it's going to be an effective approach that doesn't necessarily pan out in the end. This kind of gets to the concept of clinical equipoise. And so essentially, this is a state of uncertainty about the relative effects of the treatment being compared in a trial. So essentially, a principal investigator has to believe there's a reason to run the trial, but doesn't know whether or not the two approaches being studied, that one will be better than the other. Essentially, it assumes that while there may be a good reason to move forward with the investigational treatment, and that we believe it'll have effects that are superior to the standard of care, prior to analyzing all the data, there's no way of knowing. So what are clinical trials, or what clinical trials are? So they're an opportunity to advance knowledge of treatments for those who will be diagnosed with a similar condition in the future. Technically, as someone's enrolling in a trial, the benefit of the trial is not necessarily for the person who's being enrolled. Enrollment in these studies helps us to move forward with treatment, or helps us to do away with treatments that are not effective quicker, and advance treatments that demonstrate clinical effectiveness and get them into the clinic room more quickly. They are an opportunity for a treatment with an agent or approach that would not otherwise be available outside of a clinical trial. So many of these agents, if you think of someone's course with a brain tumor, you're going to be going from treatment to treatment. At the time of a clinical trial, that's an opportunity to be treated with a drug or approach that wouldn't necessarily be available at a different time point. So the benefits of enrollment in a clinical trial. So it's been demonstrated that subjects in a trial, so we know that subjects in a trial have a team of medical professionals keeping a closer eye on them, keeping a closer eye on their care due to the additional oversight involved with clinical research. There have actually been a number of studies that have demonstrated that people who are on a clinical trial tend to have better outcomes And it's not always the investigational arms. Often it's the people on the standard of care arms who tend to do the best. Investigational agent approaches represent one more arrow in the quiver, if you will, when it comes to treatment options. As I was saying a minute ago, there are only so many approaches that are FDA approved and available. An investigational study represents one more opportunity at a treatment that may not otherwise be available. And if we think about it, most standard of care approaches were once an investigational regimen in a clinical trial at one point in time. So how can I participate? The first thing is to ask your provider. They may be involved in clinical research themselves, or they may have insight into studies nearby that you may be eligible for. Other resources, so the ABTA has a great website. They have featured clinical studies that they've vetted. They also have links to other websites such as clinicaltrials.gov, which is a database of all clinical trials currently going on worldwide. NCI Connect, which is for some of the rarer tumors. So in terms of enrollment in a clinical trial, there are very specific times when people are eligible. So in terms of new diagnosis, so there is enrollment at the time of surgery. Often this is a very hectic time. People are just finding out that they have a tumor. But in the setting where surgery is not emergent, they may be eligible for a study that is taking place at the time of their surgery. Their tissue could be used to make a vaccine. Sometimes there are certain injections, immunotherapy and viral or other vectors that can be injected at the time of surgery. So this is something to consider if time and the clinical situation allow. The most common time for newly diagnosed is at the time of treatment start. So somebody's had their surgery, they have a diagnosis, they have all of the molecular information, and we're looking at potentially adding in a new treatment with radiation, or we're looking at adding in a new approach prior to treatment starting. Occasionally, you'll find studies, for example, in glioblastoma patients, where they've gone through their standard radiation and chemotherapy, their 6 weeks is done, and prior to the start of their monthly treatment, there are studies that can enroll. This is not common, but they do happen. Also at recurrent or tumor progression. So one of the things to take into consideration is, is the study for someone at the time of their first recurrence or second recurrence, or does it allow for any number of recurrences? Often phase 2 or phase 3 studies are looking at people in their first or second recurrence, whereas some of the earlier phase studies, the phase 0 or phase 1, are often more forgiving with respect to the number of progressions. Surgical, is it a surgical or is it a medical trial? Kind of going back to the newly diagnosed scenario, if someone has a recurrence of their tumor and they're eligible for surgery, they may be eligible for a trial that enrolls at that time point, where if their surgery is undertaken, they'll lose that eligibility, versus medical trials where usually those are a little bit more forgiving from a time standpoint. Looking at some of the eligibility, ineligibility concepts. So there are tumor-specific concepts. So as I was mentioning earlier, the WHO classification system changed recently. One of the things that it does is separate out tumors based on their IDH status. And because of this, trials more and more in the current era will look at IDH status as an eligibility criteria. MGMT status. So there is a marker in glioblastoma and other malignant or in other gliomas. MGMT can be methylated or unmethylated. In the unmethylated setting, many studies are looking at treatment options after radiation that don't include temozolomide because of some of the questionable benefit in MGMT unmethylated tumors. Other molecular pathway status. So sometimes we're looking to make sure that your tumor has a certain mutation so that the drug that's being tested is effective, or extent of resection. Sometimes studies are looking for people who had a complete tumor resection or biopsy only, for example. So the asterisk next to other molecular pathway status, this is information from the Cancer Genome Atlas when the GBM genome was mapped back in the late 2000s. What they demonstrated were a number of molecular pathways that were commonly mutated in glioblastoma. And so many drugs, so these are pathways that are mutated in many other different types of cancer. And so some drugs on the market already target these pathways, but many of the newer investigational drugs are specifically targeting these and other newer, more recently identified pathways. The concept of performance status. So often we are looking to make sure that people who are enrolled in these studies using investigational drugs that may have unexpected toxicity are able to tolerate some of these treatments. So we look at performance status. On the left is something called the Karnofsky performance status. On the right is the ECOG. They're kind of equivalent in many ways, but oftentimes the minimum requirement is that somebody is able to take care of most of their self-care to be able to enroll in a trial. Comorbidity status. So with many of the immunotherapies, we want to make sure that somebody does not have an underlying autoimmune disorder that may be worsened by treatment with an immunotherapy. Receipt of previous treatment. So sometimes we're studying a drug and we don't want somebody who's been treated with an earlier version of a similar drug in that trial because it makes it difficult to interpret. So active areas of research in brain tumors. So cytotoxic drugs, these are your classical chemotherapies. These are substances that destroy cells. They're not selective. Recent examples, VAL-083, this is a drug that's been studied over the last number of years and recently had some data that was presented at ASCO. So this is a small molecule, bifunctional alkylating agent, so similar in a way to temozolomide. It gets across the blood-brain barrier well, and it was designed to function irrespective of MGMT methylation status. It's been studied widely in different cancers, including glioblastoma. Targeted therapies, when we go back to that pathway cartoon that we looked at a minute ago, these are therapies that interact with or block the synthesis of specific cellular components. Essentially, those mutations that we were demonstrating earlier, these therapies are designed to interrupt whatever the malfunction is that those mutations provide. Recent examples, IDH inhibitors. So this is something that these have been around for a while, but the newer versions of them get into the brain better and are showing a lot more activity in brain tumors. So these inhibitors block the activity of abnormal IDH1 and IDH2 protein in cancer cells. mTOR inhibitors, so this is a downstream target of one of the pathways listed earlier. It's the mammalian target of rapamycin. It's effective in many different types of cancer, and it's been so there's been recent evidence at the current ASCO, and we'll cover this in a little bit, demonstrating benefit in MGMT promoter unmethylated glioma. Drug delivery has been a topic of research and investigation for many years, well before I did my training. So essentially, the blood-brain barrier, evolutionarily speaking, has been, kind of designed to keep out toxins and other things that impact brain function. Unfortunately, many of the traditional treatments that we've used for cancer don't cross the blood-brain barrier well. methods have been looked at in order to circumvent this. Recent examples: focused ultrasound. So essentially, this utilizes a low-intensity ultrasound to temporarily disrupt the blood-brain barrier. I had one of the investigators describe it to me as almost like putting a speaker right next to the brain. So these devices can be implantable or external, and studies have demonstrated that there's increased permeability of otherwise minimally brain penetrant chemotherapy. So some of the traditional larger molecule chemotherapies following this treatment. Interestingly, there have also been a number of recent studies demonstrating that focused ultrasound to a tumor may also disrupt some of the structures and increase the viability of liquid biopsy. So collecting circulating tumor DNA or markers in the blood of a brain tumor has been difficult, presumably because of the blood-brain barrier, but using this may actually improve the sensitivity of those tests. Nanoparticles, these are unique particles that are designed to cross the blood-brain barrier. There are a number of different approaches with these. Some of them carry chemotherapy in high doses and target tumors. These particles that are broad. They have a wide variety of properties, including some that are ferromagnetic to allow for targeting tumors by MRI or actually assisting in MRI sensitivity. Immunotherapy. So this has been an approach that has, over the last 10 years, revolutionized cancer care. It has not had as big of an impact at this point in time in brain tumor treatment because the immune system tends to function a bit differently in the brain. But this is a treatment that modulates a person's own immune system to fight cancer. The traditional treatments have been PD-1, PD-L1, and CTLA inhibitors. Essentially, what this does is shut down the signal that of negative feedback that would otherwise turn off the immune system. This allows the immune system to better attack cancer cells. An approach that is growing in popularity as techniques improve are CAR T cells. This stands for chimeric antigen receptor T cells. Essentially, a person's killer T cells are genetically modified by putting a receptor on the T cell that recognizes proteins on the surface of a tumor. These cell populations are then expanded and given back to a patient so that these T cells directly attack tumor cells. Recent successes in brain tumor treatment. So there have been a number of practice-changing studies over the last several years. This study, dabrafenib plus trametinib in pediatric glioma with BRAF V600 mutations was a study. So BRAF V600 mutations were first recognized in melanoma. There are drugs that were designed to target this mutation. Many of them get across the brain. In pediatric brain tumors, many of these tumors have a BRAF V600E mutation. So this study was done to look to see whether or not the combination of dabrafenib, a BRAF inhibitor, and trametinib, a MEK inhibitor, is better than the standard of care approach with children with brain tumors. The response rate was 47% in the BRAF MEK arm and 11% in the standard of care arm. Clinical benefits, so people who had a complete response, partial response, or stable disease was 86% in children treated with the BRAF MEK inhibition versus 46% in the standard of care. Median progression-free survival, so how long on treatment before the tumor progressed, was 21 months in the BRAF inhibition arm and only 7.4 months in the standard of care arm. The other thing to note is that the adverse events, so the toxicity from the treatment, was only half in the BRAF arm, the BRAF inhibition arm, as opposed to the standard of care. So on every metric, this was a better approach for children with a BRAF V600E mutated tumor. So another study that was recently demonstrated, so belzutifan is a drug that is something called a HIF2 alpha inhibitor. People with von Hippel-Lindau disease, this is a tumor predisposition syndrome, can have renal tumors, they can have skin tumors, they can have hemangioblastomas, which are tumors, vascular tumors in the nervous system. So this was a subgroup analysis of a broader study. The results, so this is a rare disease, so this was only a single arm study. There were 50 CNS patients analyzed as part of the subgroup analysis who were treated with this medication daily. They had an overall response rate, so shrinking of their tumor by, and I'm not sure what the cutoff was, a certain percentage of 44%, but a disease control rate, so complete response, partial response, or stable disease of over 90%. And the duration of response, so the length of time that people responded to this drug was not reached in this study. So this is kind of transformed the way that we treat von Hippel-Lindau patients with hemangioblastoma. A study out of Memorial Sloan Kettering looked at proton craniospinal irradiation versus photon-involved field radiotherapy in patients with leptomeningeal disease. So leptomeningeal disease is when cancer gets into the spinal fluid. It's a very difficult condition to treat. This was a randomized phase 2. It demonstrated significant improvement in progression-free and overall survival in people who received the craniospinal radiation. The more important thing, from my perspective, the thing that makes this a viable treatment option is the toxicity of proton craniospinal irradiation was significantly less than when we do this with photons. Proton radiation is much more precise, and so it limited some of the side effects, and it makes it a viable option for certain patients. Probably the most talked about study over the last several years is the Indigo study. This was a study of vorasidenib in IDH1 or IDH2 mutated low-grade glioma. This was a double-blind phase 3 trial. Patients who had residual or recurrent grade 2 IDH mutated glioma without prior treatment were eligible for this study. So these were patients who normally we would just be watching. We didn't necessarily feel like there was an indication to get started on treatment immediately. And so 331 patients were enrolled. About half of them were put on the vorasidenib arm versus half on the placebo arm. So these patients were essentially not on treatment. And it demonstrated a progression-free survival of 27.7 months versus 11 in the placebo arm. The adverse events or the toxicity was pretty limited as well. So what does the future hold? So there were a number of exciting early phase trials presented at ASCO this year. The N2-M2 NOAA-20 trial was an umbrella trial looking at molecularly matched people with patients with GBM who were enrolled in a trial that had potentially 4 different treatment approaches. One of the treatment approaches, temsirolimus, was effective in patients whose tumor harbored an activated mTOR pathway mutation. Also presented was a tucatinib trastuzumab capecitabine regimen for patients with leptomeningeal metastasis in HER2-positive breast cancer. As I mentioned a minute ago, leptomeningeal disease is a very difficult condition to treat. Using only systemic medicines, there was a 38% objective response rate and 100% clinical benefit rate in patients enrolled in this study. So this is very exciting in terms of approaches for treatment for leptomeningeal disease. Presumably other drugs for other molecular signatures in tumors will emulate this in the future. 58% of patients enrolled in this study who had neurologic deficits at baseline experienced improvement. So not only an improvement in effectiveness of the treatment, but people felt better because of it. So there was also a study presented at SNO in 2023 of a radiosensitizer in people with newly diagnosed high-grade glioma, demonstrating a significant median overall survival benefit. So likely this is something that will be put forward in larger studies in the future. Means to accelerate drug discovery. So novel clinical trial design. We talked a little bit. We talked a little bit about statistical approaches to make studies more efficient. Agile is an adaptive randomized design. So essentially what that means is, as opposed to the old two-arm study that enrolled X number of patients and compared them directly, adaptive randomized studies look at information as it's being obtained, as it's being accumulated, and they make adjustments to the study in real time. So the Agile study evaluates multiple agents in a single trial from numerous pharmaceutical companies in both the newly diagnosed and recurrent setting. Accrual to these arms is adjusted by performance. What does that mean? So if one of the drugs is not performing well for somebody with a tumor with a certain molecular signature, the likelihood of being put on that arm decreases. If a drug is not doing well in general, the likelihood of being put on that arm decreases. On the flip side, if one of the drugs is showing good performance in a certain molecular signature or in general, the likelihood of being put on that arm goes up. So from a patient perspective, the likelihood of being put on a treatment that's going to benefit them is increased in this study. Arms that are performing poorly drop out for futility. Arms that are performing well graduate to a phase 3 trial to go on to registration with the FDA if positive. I mentioned before the novel trial design, phase 0 studies, window of opportunity studies. So essentially, this in the earliest stage is able to determine if a drug penetrates the brain, does it hit the target appropriately, and does it have the intended effect? And so if it doesn't, these drugs are not put forward as a larger clinical trial. If it does, especially in patients who have tumors demonstrated efficacy, window of opportunity studies enable these patients to be put on these drugs in therapeutic doses to assess the effectiveness of treatment in real time. One of these approaches was presented at ASCO this year. This was niraparib efficacy in patients with newly diagnosed glioblastoma, clinical readout of a phase 0-2 trigger trial. So there were 46 patients enrolled, all met the pharmacokinetic threshold, meaning when they looked at the tumor tissue, all of the people enrolled, the drug was in sufficient concentrations to be effective as a treatment. Niraparib is a PARP inhibitor. PARP stands for poly-ADP ribose. I forget what the P is in PARP, actually. But poly-ADP ribose was suppressed in 73% of the tissue of patients who were treated with this drug. And in MGMT unmethylated patients, 70% of those patients were ultimately enrolled into the phase 2 study, the window of opportunity portion. The median overall survival of those enrolled was 20.3 months, which is significant considering they're MGMT unmethylated patients. Because of these results, there is a global phase 3 open label study of niraparib versus temozolomide moving forward in MGMT unmethylated patients. So immunotherapy approaches, so CAR T cells, over the years, this is something that has become more and more reported on at conferences as the technology is refined and more early studies in glioma are reported each year. So I expect that Similar to immunotherapies and other therapies, usually there's a window of 5 to 10 years that you hear about these approaches before they become much more commonplace in clinical trials. Other immunomodulatory approaches, dendritic cell vaccines, where dendritic cells are exposed to tumor antigens and then developed into a vaccine to trigger T cells. There's also vaccine-mediated adoptive T cell therapy, where cancer antigens are used to make a vaccine. The vaccine is administered to generate a T cell response, and those T cells are then obtained, and ones that are cancer specific are then amplified and then given back to the patient as a treatment approach. So biomarkers essentially are ways of looking in blood or other tissue at response to therapy or presence of tumor. As I was kind of alluding to earlier, due to the blood-brain barrier, many of the circulating tumor DNA or liquid biopsy approaches have not been as effective in brain tumor patients. But as the sensitivity of these assays improve, liquid biopsy for brain tumor diagnosis and response assessment becomes a more viable option. Modulating tumor microenvironment. So tumor microenvironment basically looks at what does the brain surrounding the tumor look like in the tumor environment versus the normal environment. How is the blood-brain barrier impacted? What are oxygen levels? What's blood flow? The other thing that's commonly referred to is what does the immune microenvironment look like? So brain tumors are considered immune cold tumors, meaning there's not a lot of immune cells in the tumor. And so how do we take that microenvironment and turn it into a hot environment where the immune system has more of an effect? So with that, I will finish the talk and take any questions.
Thank you so much, Dr. Mammoser. Just as a reminder, if you have questions that you'd like to ask, please type and submit it using the Q&A button, and we will answer as many questions as we can. So one of the first questions we have here, Dr. Mammoser, is asking about gaining access to trials. Do you have any suggestions on what patients themselves can do to try to gain access to trial drugs in a quicker way?
And so when you say in a quicker way, I'm not sure. So if you're meaning like how to enroll or how to get access to the trial itself, a lot of that, so kind of going back to the slide, so asking your treating provider, so your oncologist, your surgeon, whomever, will probably be the best way of getting a sense of what's in your immediate community. The websites and stuff that are out there, I think the ABTA websites are great. I think there are other websites, community websites that also distill out that information very well. Sometimes clinicaltrials.gov can be a little bit unwieldy, even for a clinician. You don't always know if trials are enrolling. We know that they're open. We don't know if they're on hold or anything like that. You know, the thing that often in my experience makes enrolling in a trial difficult is sometimes not having a real clear game plan. That may sound a little bit counterintuitive, but so when the diagnosis happens, so at the time of initial presentation, often it's a time of great upheaval, and people are kind of learning on the fly about their diagnosis and trying to find a way through it. And in the process of doing that, sometimes people reach out in many different directions. And one of the things that is very important when it comes to enrolling in clinical trials is the tumor tissue. And if somebody is getting various different opinions and things, not that I'm discouraging second opinions by any means, but understand that institutions reach out and, get that tissue and start their own direction. And so I think sitting down with your initial provider and talking through a plan of how to do it in the most succinct way, because it's a lot of data gathering, but it's also doing that in a time frame where people are learning about a diagnosis, learning about treatment approaches, and trying to maximize their time so there aren't any missteps. And that's hard to do without asking somebody who doesn't have expertise in it. If you don't have that expertise locally, say you're in a rural community that doesn't have subspecialists and stuff, you can always reach out to larger centers. You can reach out to the National Cancer Institute. There are many different resources out there meant to try and guide you through what is a very tumultuous time.
Thank you so much for sharing that advice and some of those resources. You also talked about vorasidenib, and we know that this shows promising use for IDH mutated glioma. Is there any potential for this treatment to be useful for IDH wild type as well?
So this is a drug that targets IDH mutation specifically. And so essentially it is undoing the work of the abnormal metabolite that IDH mutations are responsible for creating. So I don't think there's likely going to be a role in IDH wild type tumors.
Thank you so much. We have a question here asking if you can talk a little bit about DC-VAX, what that is and what that might mean for brain tumor treatment.
Yeah, so DC-VAX was a study that was kind of ongoing over a long period of time. It recently published some results a couple of years back. Essentially, DC-VAX is taking a part of your tumor, and also taking your dendritic cells. So there's something called leukapheresis where you undergo a process of collecting blood cells, basically. Your dendritic cells are separated out of that, and they're exposed to proteins from your tumor to kind of let those cells, so your immune system, before it's kind of primed, it responds to different antigens or different proteins. Those dendritic cells then recognize the tumor proteins as abnormal. And when that vaccine is then, vaccine is generated and it's administered back, it should help your immune system to target your tumor better. There have been a lot of different dendritic cell vaccine approaches over the years. I think with respect to some of the information that was presented a couple of years back, I think they're still working through exactly how that fits into everyday brain tumor treatment. I think there are a number of approaches that have kind of been, I don't want to say modified or refined in the time since that was kind of first initiated.
Thank you so much. We have another question here just asking more about how clinical trials work. So do all clinical trials have to combine both standard of care as well as the trial treatment? And can you maybe expand a little bit about how that works?
Yeah, so it kind of depends on which phase of the trial. Some of the earlier phase trials, and I may not be understanding this or answering this correctly, but some of the earlier phase trials may just have a single arm that has, the investigational agent if it's for a recurrent patient with a recurrent tumor. In terms of somebody who has a newly diagnosed tumor, oftentimes the investigational approach is going to be combined with the standard of care treatment. So if we're using glioblastoma as the example, that initial 6 weeks of radiation with temozolomide, you're still likely going to get that, but there may be an additional drug added in with it. Or after that radiation and temozolomide is done, after your 4-week break and starting on the monthly chemotherapy, there may be an additional chemotherapy or treatment added in with it. The caveat is, for people who have, for example, an unmethylated tumor, there's question of whether or not that approach is as effective. And so some of the newer approaches may omit the temozolomide. The radiation may be the same, but they may replace the temozolomide with a different agent that they believe is going to have a better effect. For larger phase 3 studies, usually there is going to be your standard of care arm, which means one of the groups is going to get the standard treatment so that the investigational approach can be compared directly to it so that we can determine whether or not that newer approach is more effective.
Thank you so much for helping to explain that process a little better. That is all the time that we have for questions for today's webinar. Thank you so much, Dr. Mammoser, again for your wonderful presentation and for your thoughtful answers to all of these questions. And a special thank you to each and every one of our attendees for joining us online and sharing your questions. We hope that you have found this webinar to be informative and beneficial. We encourage you to take a few minutes to complete our webinar survey by scanning the QR code on your smartphone or going to the link on the screen. Your feedback is important to us as we plan for future programs. You will also receive a link to complete the survey along with the webinar recording in a follow-up email message in the next few days. If you're looking for more content like this, please check out our next webinar, Advancements in Treating Glioblastoma, presented by Dr. Jonathan Sherman, taking place July 30th at 1 p.m. Central Time. For more information about ABTA's programs, events, and services, visit ABTA's website at abta.org, email us at info@abta.org, or call the ABTA Care Line at 1-800-886-2282. This now concludes our webinar. Thank you again for joining us and enjoy the rest of your day.
Thanks.